Listeners, I am pleased to have you join me for yet another edition of Optimal Anesthesia. Now we're going to go deep into the interesting topic of patent foramen ovale, or PFO, and its relevance in the perioperative period. We'll go over what PFO is, why it could be a problem during surgery, and how to fix it. Put in your earbuds and we'll begin. Alright, let's start with the basics. What exactly is a PFO? Well, it's like a secret door in your heart, allowing blood to pass from the right atrium to the left atrium. Most of the time, it's no big deal, just hanging out quietly. But sometimes, it can cause trouble. Now, imagine you're in the middle of surgery. What's the connection between PFO and the perioperative period? During certain procedures, like central venous catheterization, there's a risk of paradoxical embolism, and PFO can be part of that puzzle. Well, a PFO can be a hidden risk factor during surgery. Our first surgical context is central venous catheterization. Picture this, a medical professional inserting a catheter into a central vein. Now, here's the twist, there's a risk of paradoxical embolism when venous air embolism occurs. That's when air bubbles find their way into your bloodstream. If you have a PFO, these bubbles can take a shortcut to your brain, causing a stroke or other complications. So, what can be done to manage this? Well, consider hyperbaric oxygenation as a treatment. It helps reduce those pesky air bubbles and prevents them from reaching the brain. Moving on to mechanical ventilation. In some surgeries, patients require assistance to breathe. Here's the twist with a PFO. When positive end expiratory pressure is used, it can increase right to left shunting, allowing blood to bypass the lungs. The key here is to exercise caution. If your medical team knows you have a PFO, they might want to avoid high PEEP levels or find alternative ways to manage your breathing. Neurosurgery can be intense, and one thing you might not think about is the risk of paradoxical air embolism when patients are placed in a sitting position. That's right, the PFO might reveal itself when you least expect it. Preoperative PFO assessment is crucial. If necessary, they may need to change your position to avoid complications. Next up, orthopedic surgery. People with a PFO are at an increased risk of paradoxical embolism when they have deep venous thrombosis, DVT, or fat embolism. That's a double whammy of risks right there. So, what's the game plan? Keep an eye out for signs of embolism like chest pain or shortness of breath, and provide appropriate management. It's all about early detection and intervention. Thoracic surgery, specifically right pneumonectomy, can lead to a curious condition known as platapnea. This is when you suddenly have difficulty breathing when you change positions. For patients with a PFO, it's important to recognize potential platapnea and manage it accordingly. Understanding the cause can lead to effective treatment. And now, the grand finale, cardiac surgery. Even when dealing with the heart, a PFO can still throw a curveball. It can lead to transient right ventricular dysfunction, pericardial effusion, or even a myocardial infarction. So, what's the key here? Monitor for hypoxemia, which is low oxygen levels in the blood, and consider relevant interventions if necessary. It's all about staying vigilant. Lastly, let's not forget the other surgical procedures. Surgeries can sometimes involve pressure changes and air embolisms, which may pose a risk for those with a PFO. It's all about vigilant PFO management during these specific procedures, ensuring that the medical team is aware of the potential complications and ready to respond. So, let's break down the management options available to you. First up, we've got the inotropes and nitric oxide approach. This one's like the magician's trick of medicine. Inotropes and nitric oxide can be administered to reduce right atrial pressure and mitigate right-to-left shunting. It's like pulling a rabbit out of a hat, only in this case, it's reducing pressure and shunting. Next on our list is thrombolysis. Imagine a high-stakes detective story. If there's a thrombus formation in the plot, we might need to call in the thrombolytic agents to prevent further embolism. It's like sending in the detectives to solve the mystery of the clot. Anticoagulation therapy is the Sherlock Holmes of this story. It's here to prevent thrombus formation. Picture it as the wise detective who prevents crimes before they even happen. But wait. There's one more trick up our sleeve, and it's a showstopper. PFO closure. If it's necessary, you can achieve PFO closure through open-heart surgery or a percutaneous procedure. Think of this as the grand finale of our magic show, where the heart gets its happy ending, all sealed up. And there you have it, our magic show of PFO management during the perioperative period. Inotropes, nitric oxide, thrombolysis, anticoagulation, and the grand finale, PFO closure. So, the next time you find yourself in a perioperative situation with a significant PFO, remember, you've got an array of options at your disposal. Each of them is like a different act in our magical performance. That's a wrap for today's episode. We've journeyed through the mysteries of PFO, its role in surgery, and how the medical community manages it effectively in the perioperative period. Remember, knowledge is the key to improved patient care. Stay curious and keep those questions coming. Thank you for joining us on Optimal Anesthesia. Until our next episode, stay healthy and stay informed.